Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Imagine executing just a flawless, life-saving surgery, only to realize that the second you close the abdomen, you virtually guaranteed your patient, up to a 50% chance of a structural failure within 2 years.
Yeah, it's a sobering reality for sure.
Right. I mean, that is the reality of stoma formation. You know, you're going in, you are altering human anatomy to save a life, and there's this heavy expectation of precision.
Absolutely.
But if you're a surgeon or a doctor or a medical trainee listening to this deep dive right now, you already know the human body frequently refuses to follow the anatomical blueprint.
Oh, it really does.
Stoma creation is an absolutely vital procedure, yet the complication rates are staggering. Depending on patient factors and surgical technique, we're looking at failure rates ranging from 10% all the way up to 70%.
Which is just a massive range.
Oh.
And we spend years in surgical training mastering the precise tissue handling required to create the perfect stoma. But the hard truth is that the creation is really just day zero. I mean, the true clinical challenge is anticipating, identifying, and managing everything that happens after the patient leaves the operating room.
Which brings us to our mission for today. We are pulling from a massive stack of sources today. Recent systematic reviews, postoperative care guidelines, surgical technique papers.
That's clinical observation studies.
Yeah, exactly. To map out the specific critical decision points in stoma management, we really want to equip you with the why and the how behind these complications.
Because you need to distinguish between what can be managed with, simple ward care and what demands an urgent relaparotomy.
Exactly. We're covering everything from immediate 30-day vascular crises to the late structural failures that emerge, months or years down the line. So, okay, let's unpack this.
Let's do it.
But before we jump into the deep end, we do have to establish some clinical parameters.
Right. It is critical to state that this content is strictly for educational reference and synthesis of current literature.
Yeah.
While we will be discussing advanced clinical management and surgical decision-making, you must always follow your local guidelines, institutional protocols, and, of course, your senior attending's direction in your actual clinical practice.
Perfect. So let's start with the immediate aftermath. The critical first 30 days.
The acute phase.
Right. Before anyone even begins to consider long-term appliance fitting or bowel transit times, the absolute primary battleground is tissue viability.
Yeah, the overriding question on post-op day one is simply, is this bowel going to survive the week?
Exactly. So what are we looking at there?
You are looking squarely at ischaemia necrosis. Structurally, when you create a stoma, you're forcing the bowel to rely on a heavily manipulated, delicate vascular supply.
It's essentially running on a backup generator.
And that's a great way to put it. And the complications here stem from two distinct physiological failures: inadequate arterial inflow, or often more insidiously, venous outflow obstruction.
Okay, break that down for us.
Sure. If the arterial supply is compromised, maybe from overzealous division of the mesentery, the tissue turns pale and dusky.
Makes sense.
But if the fascial aperture is too tight, it actually pinches off the low-pressure venous return, while the high-pressure arterial blood just keeps pumping in.
Oh, wow, so it's trapped.
Exactly. The capillary beds become massively engorged, and the stoma turns a deep, cyanotic, sometimes frankly black color due to that venous congestion.
The literature emphasizes that certain patients are basically wheeled into the OR with the decks stacked against them, right? Like emergency surgery settings or inadequate mobilization causing high tension.
Right, and poorly sized fascial defects.
But the demographic factor that really jumps out of the data here is obesity. The risk for obese patients is magnified several-fold. Mechanistically, why is a thick abdominal wall so, catastrophic for the microvasculature of a stoma?
It comes down to the absolute limits of anatomical tethering.
Okay.
A thicker abdominal wall means the bowel has to travel a significantly longer physical distance from the peritoneal cavity just to clear the skin level.
Oh, so you're pulling it further.
Right. And to achieve that reach without tension, the surgeon is forced to divide more of the mesentery. You end up sacrificing more distal vascular arcades, like the vasa recta.
Or branches of the marginal artery of Drummond.
Exactly. You are stretching compromised vascular tether to its absolute breaking point. Combine that severe devascularization with the physical compression exerted by a thick, heavy abdominal fat pad on the mesentery, and you've basically engineered the perfect biomechanical storm for ischemia.
So picture this. You're a trainee doing your morning rounds. you pull back the covers, and the stoma is looking remarkably dark.
Never a good feeling.
No, not at all. But the clinical limitation here is that you can only visually assess the tissue that sits above the skin.
Right.
How do you actually assess the depth of the necrosis at the bedside without immediately just, dragging the patient back to the operating theater?
That requires utilizing a very classic, highly effective bedside maneuver. You need to inspect the mucosa below the skin level.
Down to the fascia. Specifically down to the fascial layer, yes. To do this, you pass a lubricated glass test tube or a pediatric endoscope right into the stoma lumen.
Oh, I see.
Yeah. By shining a light down that tube, you get direct visualization of the inner mucosal wall. The definitive clinical question you're asking is, does this mucosal necrosis stop superficial to the fascial layer, or does it extend deep into the peritoneal cavity?
Let me try to visualize this with an engineering analogy rather than a biological one.
Okay, let's hear it.
It sounds a lot like threading a delicate fiber optic cable through a tight concrete conduit.
I like that.
If the outer casing gets scraped off or damaged at the exit point, which is the skin, the signal still transmits and the core integrity is mostly fine.
Exactly.
But if that cable is crimped and severed deep inside the wall at the fascial level, the entire system is dead and needs to be ripped out.
That is a perfect analogy.
But I have to push back on the conventional wisdom here for a second.
Sure. If the bedside assessment shows the necrosis is strictly superficial, just above the fascia, is it truly safe to just observe it? Leaving dead necrotic bowel tissue sitting on an open abdominal wound seems like, an open invitation for massive local sepsis.
It definitely requires significant clinical nerve, I'll give you that. But the physiology actually supports observation.
Wait, really? How?
If the ischemia is strictly mucosal and limited entirely to the tissue superior to the fascia, the deeper muscular layers and the intra-abdominal bowel are still viable.
Okay.
That superficial necrotic mucosa will eventually slow off. Underneath, the body's inflammatory response takes over, generating healthy granulation tissue that will re-epithelialize.
But there's a catch, right?
There is always a catch. This observation strategy isn't a free pass. That extensive granulation and healing process lays down heavy collagen, which creates a rigid ring of scar tissue.
Which means stenosis later on.
Precisely. It leaves the patient at a much higher risk of late complications like stenosis. But, crucially, it spares a medically fragile patient from the massive physiological hit of an immediate emergency reoperation.
But if you look down that test tube and you see black friable mucosa extending below the fascial layer,
the clinical pathway changes instantly. Full-thickness necrosis extending proximal to the fascia is an absolute mandate for urgent surgical revision.
because it'll perforate.
It will inevitably perforate inside the abdominal cavity, and when it does, you're facing massive peritoneal contamination, devastating fecal peritonitis, and profound systemic sepsis.
Wow. We also see mucocutaneous separation occurring in the same early window, right? Where the stoma literally detaches from the surrounding epidermal edge.
Yeah, that's another big one.
The sources heavily link this to patients with severe malnutrition or those on chronic high-dose corticosteroids. Mechanistically, those factors are directly stalling the inflammatory and proliferative phases of wound healing. Steroids inhibit macrophage function and suppress the fibroblasts responsible for laying down that initial collagen matrix.
The tissue simply cannot anchor itself.
So what's the play there?
Well, convex appliances to manage the defect conservatively.
Well, the body attempts secondary intention healing.
Exactly. But a deep circumferential separation with associated sepsis requires operative debridement and complete refashioning of the stoma.
Okay, so once you've secured the blood supply and established that the bowel itself will survive, the very effluent that proves the stoma is functioning becomes your next biggest enemy.
It really does.
We transition from fighting structural tissue death to managing the surface environment and the fluid dynamics of the output.
And what's fascinating here is how the physiology of the gastrointestinal tract suddenly turns against the skin.
Yeah, take parastomal skin irritation. It's often dismissed as just a simple rash, but it's a complex chemical burn, isn't it?
It is. The effluent, particularly from an ileostomy, is loaded with active proteolytic and lipolytic enzymes that were meant to digest food.
But instead they're sitting on the skin.
Right. When those enzymes make continuous contact with the epidermis, they literally digest the patient's skin.
That sounds agonizing.
It is. You combine that enzymatic destruction with a warm, moist microclimate trapped under a stoma appliance, and you create a perfect incubation chamber for opportunistic fungal and bacterial superinfections.
The clinical trap here seems to be differentiating between harmless surface issues and hidden structural catastrophes. The sources note that postoperative stomal edema is incredibly common just from the surgical handling of the bowel.
Right, and the disruption of local lymphatic drainage. The stoma gets swollen, pale, and boggy.
So how does a trainee confidently differentiate between this expected harmless lymphatic edema and an actual early mechanical obstruction or a venous ischemic event? You definitely don't want to prep a patient for an unnecessary laparotomy just because of normal swelling.
It all comes down to evaluating mucosal turgor and functional output. Edema typically peaks around 48 to 72 hours post-op.
Okay.
The stoma looks remarkably swollen, but the mucosa should still be pink and viable, and the tissue feels soft and compressible.
And ischemia.
Ischemia presents with a loss of mucosal turgor, a dusky discoloration, and a firmer, congested texture. But the ultimate tiebreaker is output.
Right. Is it working?
Exactly.
Yeah.
Is the stoma passing flatus? Is there liquid stool in the bag? If the stoma is swollen but functioning, you observe.
But if it stops?
If the output drops to absolute zero, the abdomen becomes distended and the patient develops colicky pain, you are no longer dealing with simple edema. You have to suspect an early small bowel obstruction.
That obstruction usually happens because the bowel is kinked right at the abdominal wall exit, right? Or the fascial aperture was simply sewn too tight.
Acting almost like a ligature, yes.
The initial move there is non-operative, right? Nasogastric decompression to empty the stomach, aggressive fluid resuscitation, and a contrast CT scan.
To identify the exact transition point of the
Exactly. And if the imaging suggests strangulation or closed loop obstruction, or if the patient just fails to improve with decompression, they are going back to the operating room.
But we also have to examine the complete opposite extreme of flow disruption, right? The high output stoma, or HOS.
Yes.
This is a profound medical emergency driven by the sudden loss of the colon's absorptive surface area, mostly in early ileostomies. I was reading about the specific fluid dynamics of high-output stomas, and it's totally counterintuitive.
Oh, very much so.
When a patient is dumping liters of fluid into their stoma bag, their instinct, and sometimes the instinct of junior staff, is to have them drink massive amounts of plain water to catch up.
Which is the worst thing they could do. Right. The sources point out that drinking hypotonic fluids like plain water actually worsens the dehydration. Because water lacks sodium, it creates a luminal gradient that pulls even more sodium out of the patient's serum and into the bowel.
Dragging more water with it, it is a devastating positive feedback loop. A high-output stoma rapidly drives the patient into acute kidney injury, severe hyponatremia, and profound hypomagnesemia.
So how do you stop the loop?
The management requires restricting hypotonic oral fluids and replacing those deficits intravenously with isotonic solutions. Simultaneously, you must manipulate the gut motility.
With drugs?
Yes, you deploy high-dose antimotility agents like loperamide. It works as a mu-opioid receptor agonist in the myenteric plexus of the bowel wall.
Okay.
It doesn't just stop the flow, it actively suppresses the peristaltic reflex, significantly prolonging the transit time. By slowing everything down, you increase the contact time the effluent has with the remaining healthy mucosa.
Maximizing whatever absorptive capacity is left.
Exactly.
But, gravity and intra-abdominal pressure never sleep. Even if a patient perfectly navigates the first 30 days, the ischemia, the skin burns, the fluid shifts, the biomechanics of human anatomy guarantee that chronic late-stage failures are almost inevitable.
That's the reality of it.
And the absolute biggest enemy we face in the long haul is the parastomal hernia.
So sorry for the interruption, but this is important. We need your support to help us grow, reach more surgeons, and keep delivering cutting-edge surgical content. Press the support button and donate now if you like what we do. Let's get back to the podcast.
The epidemiological data on parastomal hernias is just daunting. Systematic reviews suggest an absolute risk of around 30% at 1 year.
Wow.
And if you track patients with end colostomies beyond 2 years, that risk climbs to a staggering 50%. Half of all patients will develop a clinically detectable hernia.
Which begs the question of why we are so bad at preventing them. But when you look at the biomechanics, it makes perfect sense. The entire physiological purpose of the anterior abdominal wall is to act as a dynamic corset, right?
A corset containing the viscera against massive spikes in intra-abdominal pressure.
Yeah, from coughing, lifting, or just standing up. And to create a stoma, we deliberately cut a hole straight through the rectus abdominis muscle and the fascial aponeurosis, We are intentionally destroying the structural integrity of a pressurized container.
That's exactly it.
It feels like trying to patch a tire that you intentionally poked a hole in. When you add risk factors like older age, high BMI, or chronic respiratory conditions that cause violent coughing, a hernia isn't just a risk, it is a biomechanical certainty.
That is precisely why modern management relies heavily on prevention and conservative care. We do not rush a 50% incidence rate back to the operating room.
Right.
The vast majority of these hernias are asymptomatic or cause only mild discomfort. We manage them by optimizing the patient's weight, prescribing specialized, custom-fitted abdominal support garments.
To counteract that outward pressure.
Right, and utilizing flexible convex pouching systems that can maintain a seal over the distorted topography of the hernia bulge.
So when do you operate?
Surgical intervention is strictly reserved for hernias causing recurrent obstructive episodes, severe intractable pain, or a stoma appliance that simply cannot maintain a seal, leading to constant leakage.
Which causes severe social isolation for the patient.
Exactly.
I noticed the guidelines are incredibly prescriptive about the surgical technique when you do finally operate. They heavily favor mesh-based repair techniques, specifically the sugar baker configuration.
Performed either open or laparoscopically, yes.
And they explicitly advise against using simple primary suture repair to close the fascial defect. What is the precise mechanism that makes the sugar baker mesh so superior to just sewing the hole shut?
It all comes back to tension and physics.
Okay.
The fascial tissues surrounding a stoma are already attenuated, thinned out, and compromised. If you simply drag those weakened fascial edges together with sutures, you are creating massive circle points of tension right at the suture line.
So the moment the patient coughs,
the sutures tear right through the fascia. The recurrence rates for simple suture repairs approach 70%.
wow, that's high.
The sugar baker technique changes the mechanics entirely. Instead of pulling the defect closed, you place a large sheet of synthetic or biologic mesh intraperitoneally, covering the fascial defect and draping over the bowel as it exits the abdomen.
So it acts like a patch from the inside.
Exactly. It uses the patient's own intra-abdominal pressure to sandwich the mesh tightly against the abdominal wall. It distributes the biomechanical load across a massive surface area rather than a single line of sutures.
Two other chronic mechanical failures that frequently require intervention are prolapse and stenosis. We know loop stomas are notorious for prolapsing, right? Where the bowel intussuscepts and telescopes out through the abdominal wall.
Yes, very common. Mechanistically, loop stomas require a much larger fascial aperture to accommodate both the proximal and distal limbs of the bowel. Plus, the posterior wall of the bowel isn't fixed to the fascia, providing a massive degree of inherent mobility.
When a patient presents with a prolapse, the immediate priority is assessing the viability of that telescoped segment.
Right. If it is pink and well perfused, you teach the patient manual reduction techniques and switch them to a specialized elongated pouching system.
I was reading in the sources that one of the conservative bedside management techniques for an acutely edematous prolapse involves applying regular table sugar directly to the exposed bowel mucosa.
Yes.
That sounds like an old wives' tale until you break down the cellular mechanics at play.
It is pure applied osmotic physiology. When a prolapse becomes engorged and edematous, it's trapped outside the fascial ring. Applying a hypertonic agent like granulated sugar creates a massive immediate concentration gradient across the mucosal membrane.
And through osmosis, the sugar rapidly pulls the interstitial fluid out of the edematous bowel wall.
Exactly. The bowel visibly shrinks within minutes, making it significantly easier to manually reduce back through the fascia.
That's amazing.
However, if the prolapse segment becomes incarcerated, irreducible, or shows any signs of venous compromise or ischemia, you abandon conservative measures. That mandates immediate surgical resection or revision.
And then we have stenosis, which is essentially the biomechanical opposite of a hernia or a prolapse. The stoma aperture continuously shrinks and narrows either at the epidermal level or deep at the fascia.
Yeah.
The patient presents with profound bloating, high-pitched bowel sounds and extremely narrow ribbon-like stool output. What is fascinating is that stenosis is very often the ghost of complications past.
Precisely. Stenosis is a late consequence of the early ischemic events we discussed in the first 30 days.
Right.
If a patient experienced mucosal ischemia that slowed off, or severe mucocutaneous separation, the body heals that missing tissue by initiating a massive local inflammatory response. Fibroblasts flood the area and lay down dense collagen fibers.
And over months and years.
That scar tissue undergoes concentric cross-linking and contraction. It acts exactly like a tightening purse string, slowly and relentlessly strangling the stomal outlet.
Can you just stretch it out at the bedside?
You can attempt serial, progressive mechanical dilatation, but you are fundamentally fighting a losing battle against the biology of scar tissue. Definitive treatment usually requires returning to the operating room to excise the fibrotic ring.
As we move into the final complex edge cases, it is critical to step back from the localized mechanics. It's very easy for surgical teams to develop tunnel vision focusing entirely on the fascial defect, the mesh configuration, and the skin integrity.
Oh, absolutely.
But a stoma is deeply integrated into the patient's systemic health, and ignoring the systemic physiology can lead to catastrophic oversights.
If we connect this to the bigger picture, systemic conditions completely alter local stoma management. Stomal varices are a prime example.
Right.
In patients with severe liver cirrhosis and portal hypertension, the fibrotic liver acts as a dam, blocking venous return from the splanchnic bed. The venous blood desperately seeks collateral pathways to bypass the liver and return to the systemic circulation.
And the stoma happens to be one of those pathways.
Exactly. The mucocutaneous junction of a stoma becomes a major site of portosystemic shunting. The fragile venous plexus around the stoma becomes massively engorged with high-pressure blood, creating varices that can spontaneously rupture,
leading to massive life-threatening hemorrhage right into the stoma bag. And a surgeon cannot fix that purely with local measures, right? Suturing or cauterizing a ruptured varix is just plugging a single leak in a pressurized pipe.
Exactly why you need a multidisciplinary systemic intervention. You use local pressure and hemostatic agents to control the immediate exsanguination, but you definitively require interventional radiology and hepatology.
For a tipped S procedure.
Right, a transjugular intrahepatic portosystemic shunt. By deploying a stent directly through the liver tissue to connect the portal vein to the hepatic vein, you create a low-resistance bypass. That immediately drops the systemic portal venous pressure, completely decompressing the stomal varices from the inside out.
Beyond complex pathophysiology like varices and Crohn's fistulae, the human element of stoma care is staggering. The literature highlights that up to 50% of all stoma patients experience profound, clinically significant psychological distress, severe anxiety, or depression.
It's a huge psychological burden.
You are abruptly altering a patient's fundamental body image, their method of waste elimination, and their basic sense of bodily control. This trauma is exponentially higher in younger patients or those facing a permanent ostomy.
Which is why the practical framework for any trainee or clinician managing these patients must be holistic.
Yeah.
In the acute postoperative phase, your physiological mantra is perfusion, fascial tension, output dynamics, and skin protection.
Right.
You maintain a razor-low threshold to escalate to your senior attending if you suspect necrosis or early obstruction. But in the late phase, your clinical focus must pivot entirely. You are no longer just looking at the bowel. You are evaluating the symptom burden.
You're assessing chronic pain, the reliability of the appliance seal, sleep disruption,
and the patient's ability to reintegrate into society.
It is a profound reminder that successfully managing a stoma patient is never a solo surgical act. It requires a highly coordinated clinical village. The operating surgeons understanding the biomechanics, the specialized stoma care nurses executing advanced wound management,
the dietitians optimizing the liminal output,
and the clinical psychology services guiding the patient through a massive identity transition.
Which leaves us with a final thought to mull over. If the human abdominal wall is fundamentally unsuited to permanently house a pressurized stoma, are we approaching the absolute limits of traditional anatomical surgery?
Oh, that's a great point.
With the rapid advancements in bioengineered sphincteric implants, tissue-integrated smart mesh that can dynamically respond to intra-abdominal pressure, and magnetically controlled continent valves, the next decade of surgical innovation might see us abandon the traditional open stoma entirely.
Wow, that is an incredible horizon to look toward and a brilliant perspective to carry into the wards tomorrow. If you like this content, do not forget to share this deep dive with at least one of your colleagues or friends to spread the word. Absolutely.
Also, check out our YouTube and other social media pages for more clinical breakdowns. And do check our previous season and deep dives, where we cover some very relevant topics for your clinical practice. Thanks for joining us in the deep end, and we'll see you next time.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.